Okay, welcome to the Duke Spine Institute. We are getting ready to start our Duke laser disc repair, first one today. We're going to be fixing 3 discs on both sides. This patient has had a prior laminectomy done. I didn't do it, somebody else did, and that was done in 2015, I believe. Sean? So she has had problems with her back more recently. Sean, I can't go into a lot of details, but it's related to a work injury on her back. That's beautiful. Let's go AP, see where we are. And she's now got 3 disc herniations, bilateral 3-4, 4-5-5-1. Sorry we don't have the MRI to show you, but they're pinching the nerves going in both legs. Okay, we're too far lateral. Feel free to ask questions if you'd like during the surgery. Shot. We're here to answer questions the best we can. Shot. 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 All right, that feels like the facet joint. Let's get an AP. So we're using X-rays, front, back, and side to side, AP and lateral, to guide. That's better. To guide the placement of our needle. We're going to be putting in 6 needles. 2 at each disc, 3, 4, 4, 5, 5, 1. And the needles will be used to, Sean, basically guide the surgery. Sean? All right, I'm pretty happy with this entry point. Is she reliable? A few more minutes. Num skin.
Hello. How are you? You okay? Okay, we're going to ask you a few questions.
If you're having any pain, please tell us. Just say ouch. And then we want to know if the ouch is in your back or in your leg. That's just medicine going in your skin to help us, because we're going to get started here. Okay, so the whole surgery is going to be done through a tiny little cut on each side called an incision. And normally incisions are really big, and for the spine, we just did one this morning. If you don't believe me, just take a look. Right, Dr. Berndes? Shot? Let me know if she's completely reliable.
How are you doing, my friend? Okay,
Good, good. Shot? Wonderful. We like patients that are doing great. Sean? So this is the L4-5 I'm going for right now. I've got the needle at the L5-S1 almost in the perfect position. Let's take an AP. So we're going to start with her left side, then we'll go to the right side. We're going to get access to all 3 bad discs. Okay, looks good. If you have questions, feel free to answer them. In the meantime, we're going to show you a video that explains why do disc injuries actually cause back pain.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Your low back? Low back.
All right. All right. You're doing great. Lay still and just help us out. We're going to have you to sleep soon. I just need your help for a few more minutes. You're doing great. Sean? So the 5-1, I'm trying to get further south, and that should do it right there. I'm working around her facet. The facet is super big, and it's right in the way. I think we've got it. And 5-1 is always the hardest to do. L4-S1, very tough to do transforaminal through the foramen. You're doing great. But we've been very, very good at getting it. You're fine. We're just talking. You're going to get to watch your surgery tomorrow. Thanks. Yeah. I'm happy with that. She's very collapsed at 5-1. And I'm right at the beginning of the disc. I don't think I can do a discogram with that. But what I'm going to try to do is when she's a little more comfortable, I'm going to try to advance 5-1 needle. I'm happy with 4-5, and we just have one more to do, L3-4. You guys ready at 3-4? Let's try to clean that up a little bit. So if you're looking at the X-ray side view, you see the 3-4, and there's some white stuff. It looks like white circles, like almost polka dots. That's actually gas in her bowels. So she hasn't eaten anything today. She's got an empty stomach. That's good. And but you know, there's still air in there, and that's what we're seeing. Okay, shot. You're doing great. Thanks so much for laying still. We're halfway done. And we're going to put you to sleep soon. You know you're having a big procedure. I think we're off on orbit. You know, there's some rotation between 3 and 4. You can see it. Shot? That's better. That is definitely better. Yeah, there's definitely rotation there. Shot? All right. Any questions from our audience?
No
Sean?
current questions.
You have a question?
No current questions.
No, she said yes.
Oh, apologies.
So I was going to give her a chance to ask.
Of course.
Wow, AP. So that is collapse again at 3-4. Are you comfy? Good. Yeah, you can see 3-4. We're in great position. All of them look good. 4-5, obviously the best. We're actually in the disc at the midline. So let me get this one started. And you have some num-num there? See, right around here. Let's give it. We're going to give you some more numbing medicine. You might feel a little stick and burn. That's normal. Don't freak out. You're doing great. Yeah, sorry about that. All right, perfect. So you're okay. Now, shot. I'm going to try to advance 3-4. Just a little more. Relax. So collapsed. So collapsed. I think I'm bumping up against a superior. end plate. Yeah. Shot. That's it right there. Uh-huh. I'm going to try to come a little bit lower. Everything okay, Luis? Shot. Where do you feel that?
Where are you feeling that?
Where?
Low back.
That's where we expect you to feel it. Shot. Feel like I got some progress there. Uh-huh. And we did. Good. You're fine. We're right in that area where your bad disc is, so we're going to expect a little bit of discomfort. Okay. We've lost maybe 3 drops of blood total so far, which is not much. Next, we're going to go to the other side and get started. Shot. All right. Very good. Lay still. You're doing good. Num num.
We have a question.
Sure.
This comes from Nick Hollywood on Facebook. And they asked,
Good.
hello to all there. Sorry for my English. I want to ask if an untreated herniated disc can cling on the spinal cord and create scar tissue, and if this makes your job more difficult,
Yeah.
and if this can cause damage on the nerves on the schedule.
Yes, Nick. Great. Was it Nick you said?
Nick, correct.
Great question. You are correct. An untreated disc herniation does cause inflammation. That does cause scarring. It can definitely get onto the spinal cord and cause more damage directly on the spinal cord. Inner back shot. Don't move, okay? You're doing great. Don't move. Shot. Just lay still. We're almost done. Shot. Yeah, that's perfect. Except my hand is in the view. AP. So you are correct. The best thing to do is to get your herniated disc fixed as soon as you find out you have one if it's causing symptoms. Because letting it go too long means it's going to do more damage. The way I like to think about a herniated disc is that when you get a herniation and there's inflammation causing pain, that inflammation is like a fire. If there is such a thing as a fire in your body, it's inflammation. That's good. Yep, you're fine. They were just giving you some more numbing medicine because we really like you a lot. We don't want you uncomfortable, okay? Sean? So once again, this is super collapsed. Super collapsed right there. The disc is. I'm right against, I could feel the herniation and the bone spurs. She's got disc osteophytes. Definitely she had problems before. You know, she had a laminectomy before. So that she was doing good with, and then she ended up having an injury that's just causing a lot of discomfort for her. So, great question. All right, shot. Need to be aiming a little south. Shot. You're great. Everything's going well. Just be patient with us. Shot. 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 Where do you feel that?
In your legs?
I'm not even near her nerve root. it's right on her facet. Shot. Let's get an AP. You're doing great. Be patient. We've got 4 needles where we need them, and we only got 2 more to go. Yep, that looks good. No, I'm not done. No, I mean it looks good, but it's not done. It looks good, but it's not in. Yeah, that's your bad disc. I know it hurts. Shot. One more to go. We got the two L4-5 needles went in perfect. The L5-S1 are really tough because it's so collapsed, and she's awake still because we haven't put her to sleep. So she's really clamping down with her muscles are tightening down onto the actual disc. You're fine. Let's give some more num-num. We'll give you some more numbing medicine. Don't worry. Check now. Good. Yep. Shot. All right. Shot. Shot. So this is the hardest part for me of the surgery, by the way, in case you're wondering. It's getting the needles into the exact spots where they're supposed to be. Oops, yeah, I'm aiming a little too high. And of course we want to do this shot by doing it through one incision if possible. Of course we're not going to compromise the quality of the surgery and just have to get it in one incision. You okay? Where do you feel that? Shot. Back or leg? I can't hear Bernadez. I need your...
She says leg. You feel that in the leg?
Where do you feel it?
Leg or back? Lower back? Yeah. Lower back.
Come on now. We need this one. We got it. Yay. That's in. Boy, it's tough. You okay? She's all right. All right. Well, the good news is we're done poking you.
So that's good news.
Yeah. We're going to put you to sleep soon. And when we're done, you're going to wake up and you're going to be done with your surgery. That's the good news. Okay? All right. We're going to do 5-1. I don't know that we can get. We'll try.
Try to keep your head really still, okay? Thank you.
Lay still, okay?
Still.
4-5. We can definitely do. And I think we can do 3-4 on this side, your side.
My side?
Yeah. So the last one at the bottom there. All right, so long story short, this lady presented with the typical complaints of back pain and leg symptoms. And the leg symptoms always come from a pinched nerve when it's related to the lower back, okay? So how do nerves get pinched? Well, basically, you have a cushion between your bones called the disc, and there's tears that happen from injuries. And then once you have a tear, the jelly in the center, it can leave through the tear and stick out outside the disc. And we call that a herniated disc, and over time they can get calcified. But the nerves, they come down from your spinal cord, which ends right around here at L1-2. And the nerves come out and they run down in your spinal canal, and then they leave. And they go out, literally leave out through holes called neuroforamen, and they run right behind the back of the disc, and they go down your leg. So you've got every nerve on the right has a pair on the left, okay? And these nerves go all the way down to your toes. So we know from our MRI, which you guys can't see, that the nerves are getting pinched on both sides at all three discs. We also know she's got back pain in this area. When I asked her, where is your back pain? She pointed here on exam. Okay, right in there. And I said, do you have pain here? She said, yes, that's L5-S1. You have pain here? Yep, L4-5. You have pain here? Yep, L3-4. So I know she's got back pain coming from those three discs based on my clinical assessment. I'd like to confirm it with what's called a discogram. Are you comfortable? All right. Are you having any pain? Nope. Good. How bad is that on a scale of 1 to 10? How high did it go? 9. Is that where you typically get back pain? So she had a 9/10 at L4-5, concordant.
Keep your head down. Please don't move.
I'm apologize. We're just testing your bad disc, okay? I don't know if I can get 3-4. We'll try. Shot. How bad is that on a scale of 1 to 10?
9.
10. 10. All right, that was a 10 out of 10 at L3-4. Okay? 10, 10, 10, she said. That's where you get back pain? All right. Now, look how thin those discs are. Jordan, show us how thin these discs are. Folks, that's 90% of the disc is gone, okay? Show us where the disc is left. Yes. Show us the tear. Yep, that's the tear. Show us the herniation. Yep, see that bulge there with the dye? That's the herniation. It's wrapping around the herniation. It's a lovely test, this discogram. That's what's crushing her nerve. Actually, you can see the nerve there. Show her the nerve. See the herniation you just showed me? Look right above it. To the left. Left. There. See the dye wrapping around the nerve? That's it right there, where the arrow is. You guys see that? Pretty cool. Herniations on it. I can't do L5-S1 because I'm not in the disc, I don't think. So if I just inject dye, it's just going to go in the epidural space. Because 5-1 is so collapsed. So I'm not doing 5-1. Take that. Now we got a lot of work ahead of us. We're going to fix 6 discs, 3 discs on 2 sides, so 6 areas. Let's start with, yeah, that's fine. 5-1 will be the toughest. Yeah, we need her to go to sleep. So let's start with 4-5. Luis?
Yeah, that's
4-5. We're going to start with 4-5 because I need these other needles out of the way. I need the lights down. Folks, you're about to witness endoscopic spine surgery, specifically the Duke laser disc repair. Now I'm going to tell you the only other surgery for this lady that would work is a fusion, where we go in and clean the disc out completely and put in new spacers. Shot? That's my guide wire. I can see it. You guys agree at L4-5? My wife always says to me, you don't know where you're going. You're always asking for directions. And I said, you should be thankful. Most guys don't ask for directions. They just drive until they get lost. I always say, should I go right here? Should I go left here? And she gives me a hard time sometimes. And I said, listen, I'm only thinking about you. Because if I do get lost, you're going to be the one who complains about it. So when I'm in the operating room, I'm always asking my team, just in case I have a brain fart. We all get brain farts, right? So by having all these smart people who know what they're doing, make sure looking over my shoulder, I'll give you 1 second, but only a second. Is that a Duke spine second? Yeah, just remember when we get to 5-1, we didn't put dye. So there's no numbing medicine in the disc either. But we're going to do that last anyway because that's the hardest one. So I'll wait till she's deep. Nice and deeply asleep. Let's show them on the x-ray, Henry, Jordan. Now go back up to L3-4 and look at all the dye. It's gone. See the thin stuff there? Remember how dark it was earlier? Because the dye leaked out through the tears in the back of the disc, the annular tears. It's gone. It's already leaked out. And all that's left is a little bit. Let me know when I can proceed. To some of you, this may actually look like a hammer. And there's a reason for that. Because it is a hammer. It's just a very expensive hammer. You ready? All right, I'm giving the green light. We can move forward. So I'm going to basically hammer this dilator in to the L4-5 disc. As I'm doing that, she's responding a little bit. As I'm doing that, I'm going to be pushing the herniation back into the disc. You see the tip of the dilator? Show the tip of the dilator. Show the herniation. You can still see an outline. That's the herniation. There's the dilator. One of the nice things about this particular type of surgery is we're actually reducing the herniation back into the disc. And then we're going to take it out from the safety of the disc. Relax, you're doing great. She's doing great. She's going to be a lot happier with this surgery than a fusion. Yep. Let's put the... Now let me show you folks. If you've never seen endoscopic spine surgery, it's all done through this right here. Looks like a pen or a straw. And indeed it is a straw. It's a metal straw. This straw, this metal straw, is over $1,000. And it's a specially made tube. It's called a tubular retractor. It's a retractor, like we use in surgery, that retracts tissues, but it's the shape of a tube. It's called a tubular retractor. It's incredibly sophisticated piece of equipment, and it makes endoscopic spine surgery possible. Beautiful. You can see the dilator is advancing too, but we're good. We are good. Great job, everyone. So far, so good. All right. We're going to do our first disc, left L4-5. Left L4-5. Remember, this patient has herniated discs on both sides, right and left, leg symptoms on both sides, weakness, numbness, tingling, and pain. So we're going to be treating and decompressing both sides. Everything okay, Monica?
Yes, I just want to know if you guys are done with OR2 for the day.
Yes, sir.
We're not doing any more surgeries in there.
Yes, sir. What do you need? You want to? Oh, okay, yeah.
I wish we had some music. Oh, look at that. There's the herniation right there, guys. Blue. We stained it blue. It is blue. Duke spine blue. Are you doing all right, doctor? Everything okay?
Yep.
All right.
Can we turn on the light, please?
Uh-huh.
No, you're good. Thank you. The light.
Wow.
Thank you.
It's kind of a weird looking disc. You can see the metal. You guys see the metal there? That's the needle from the other side. Remember, we put needles on both sides. I'm going to bring the laser in. All the leaves are brown and the sky is gray. Who's doing some California dreaming today? Anybody? Huh? If I was dreaming about California, I'd feel badly. I feel like I was cheating on Florida. I'm a one-state kind of guy. I left California back in 1996. Moved to Florida. Never had any regrets. Nothing against California. I do miss it sometimes, but that's why I travel there to visit my family.
I used to live there.
You used to live there. Berndes used to live there. How many people used to live in California here? How many? Just Dr. Berndes and I? All right. Good. So you guys see the needle? We're going to leave it alone. We're going to pull back a little bit and start working our way towards the periphery. There's a piece of herniation right there. And there it goes. Floating up, up and out. And most of the herniated pieces we don't actually grab and take out because they make their way out through the fluid that's pushing them out from the tube. We're constantly circulating fluid to cool the laser and remove the debris. Debris is spelled D-E-B-R-I-S, debris. The debris we're talking about is the debris of the herniated disc. As the laser zaps it and breaks it up into little pieces, it forms debris. Not the brie, as in the brie cheese. This is debris, D-E-B-R-I-S. It's a medical term. It means pieces of tissue, whether it's bone, ligaments, disc, bacteria, not in this case, of course, but it's a all-purpose term, right? It's kind of like saying anesthesia. Doesn't mean anything because it doesn't tell you the kind of anesthesia, but it just is a general term. All right, looking good. Not much disc left. All right, she's had some pretty bad damage to these discs over time. They're quite collapsed, but that's okay. We're going to get rid of the back pain from these discs. We're going to get rid of the leg pinched nerves from the disc as well.
Keep your arms still. You're doing great. Keep your hands.
We have a question.
I'm happy to take the questions.
This comes from Meowosaurus on YouTube.
The outsource.
Meowosaurus.
I'm sorry. Okay, very good. Thanks for asking a question.
And they ask, what inspired you to create the DLDR? At what point in your career did you realize there was a better, safer way to treat back pain?
That's a great question. Thank you for asking. I didn't really honestly set out to do a better treatment. I just wanted to find the best treatment that was already there. I never really saw myself as a creator of anything. I just saw myself as wanting to do what's best for the patient. So I kind of went around not ever thinking of myself as being good enough to create anything, but at least good enough to copy somebody who already created something. So of course I copied my professors who taught me as a neurosurgeon. I copied them, they showed me, and I copied them with fusions and laminectomies, and I did a really good job with those, and I perfected them, and I did them really well. And then one day, somebody said to me, you should go see laser spine surgery. And I've told the story a few times, and I tell you the truth, I thought it was a joke, because of course I trained at literally the very best neurosurgery training program in the world. And that was in Gainesville, Florida, Shands Hospital, University of Florida. And I thought, well, we didn't do that there, so it must not be real, because, you know, when you literally you're trained as one of the 2 residents selected every year at the top neurosurgery program that does spine surgery and brain surgery, you believe that what you're going to learn there is the very best techniques. And I believe I did learn the best techniques for fusions and laminectomies and all the traditional surgeries. It was very good. I learned the best techniques from the best surgeons. However, when somebody mentioned laser surgery, I at first thought it was a joke. I didn't believe it, but my wife convinced me, go check it out, see what it's about, be open-minded. And I have to admit, if it wasn't for her, I don't think I would have ever gone. I had gone already at that point to a place called the Bonatti Institute in Florida to see what his procedure was about. And I wasn't impressed at all. I thought he was just a scam, a marketing scam. You know, sorry, I'm just telling you the truth. Anyway, so I went to see this surgery done. The surgeon's name was Dr. Tony Young. He was in Phoenix, and he was willing to teach endoscopic lumbar, which is what I'm doing now, lumbar endoscopic surgery to a few surgeons. And he agreed to teach me because I guess he liked me and felt that I would make a good student for his technique. So of course I went there and I saw what he was doing, and I almost literally fell out of my shoes. I mean, I never seen anything like it before. This tube in the back coming from the side. I thought, this is crazy, you know. If it was so good, my attendings would have taught me this. But, you know, clearly this must be voodoo witchcraft. And by the end of the 3 days in Phoenix, Arizona, at his center, I was literally eating out of his hand like a little pet animal. I was in shock. I was just in disbelief that this could be so amazing that I had never seen it before at my top training program. So I, of course, wanted to learn endoscopic, but of course he didn't do the Duke laser disc repair. He did a type of transforaminal endoscopic surgery, and it was good. He used the grabbers, he used the bipolar, which we don't use because it doesn't work that well. But, you know, I love Dr. Young, my mentor. I'm his protege. But it turns out, I found out that, of course, he made a lot of money by selling his system and selling his equipment, his bipolar. Well, I didn't think the bipolar worked that well, so I ended up not doing the bipolar, and I incorporated the laser. And I like the laser. It's more precise. So I started doing the laser, and I was getting really good results, not just with leg pain. Okay, everyone does this for leg pain. I was getting back pain results, like the back pain will go away. And I didn't expect that from the patients at all, because I thought you had to fuse to get rid of back pain. So when I saw the patients come back, and I was thinking to myself, there's no way I'd get rid of their back pain. Yeah, leg pain, yes, not back pain. And then I was seeing the back pain gone. And I started to wonder, what am I doing different than everyone else? And I realized I was doing what's called a debridement, an annular debridement, which is what I'm doing right now, by the way. So I'm not just removing the herniation, I'm actually cleaning the tear in the back of the annulus. And by doing this with a laser, it got rid of the back pain. So I have to say, I didn't set out expecting to change the world. I just wanted to do a better job as a surgeon for my patients. But somehow, and I don't know how still, it just fell into my lap, this technology, this ability. And I guess just because I cared and I assessed what I was doing and to see if I could make it better for my patients, and I did. And now I have this treatment that apparently, you know, other doctors couldn't have figured out themselves. Of course they could if they spent the time. And then I started asking, why don't they? And I realized they're just so enamored with this whole culture of fusions and metal. It's really big, you know, it's really powerful. If you want to be in a clique, you want to be in a group. I've never been the cliquey type, ever. I've always avoided cliques when I was younger. I hated them. So I never wanted to be part of a group of people that excluded others. I was always all about everyone doing things together, you know, inclusive, not excluding people. So I realized that in spine surgery, there's these groups that are controlled by the companies that make the screws and rods and cages. And of course, those companies have a financial interest in keeping this culture of fusion going. And it's pervasive in spine. I just went to a meeting in Utah like a week ago with Arias, my research fellow, and everyone there is doing metal surgeries, the kind of stuff I was doing 25 years ago. I mean, they haven't moved beyond that. They're just putting more screws, and all right, instead of just a regular metal screw, they're covering it with hydroxyapatite, you know, which is basically bone to stimulate bone growing into the screw. And that's a huge thing, you know. But it's not. It's not a huge thing. In their minds, it's a huge thing, but for the patients, it's bad. It just means they're going to do more surgeries with screws and rods when they should be doing less. So I was able to talk to these surgeons. They asked me, what would you do in this case? And I said I would do endoscopic. And none of them do endoscopic surgery. So I was kind of like the black sheep in the room, so to speak. I don't know if that's politically correct, but I was the guy that I wasn't very popular because I was doing something none of them knew how to do and didn't involve putting metal in people. And they didn't understand what I was doing. They had no clue. And I have to admit, when I got done with my training, I wouldn't have a clue what I was doing either. But it took years of developing and practice and modifying my technique to make it better, focusing on the things that work, getting rid of the things that don't work. Anyway, we're done here. I like that. We got decompression there. It looks pretty good. I feel pretty good. I may want to get a little bit more medial towards the midline. I apologize for the red. I can't help that. A little bit of bleeding. Anyway, that's how I ended up where I am now. So it was not intentional. It just happened. And I'm really happy that it did, because I'm going to take this and I'm going to fight the system for my patients to do a better job. Yep. Thanks. Because a lot of doctors don't fight to do what's best for their patients. They do really what's best for themselves. And I guess I'm happy that I was chosen to do this, because I will fight for my patients to get the best care possible. I'll fight the insurance companies. The hospitals I worked at, 2 of them in particular, I approached the CEOs, met with them, told them I want to do these laser surgeries, and they did not allow me to. They wouldn't buy the equipment. This was 16 years ago. They wouldn't spend the money. They weren't interested. They just wanted to keep doing fusions. And they wouldn't invest. They wouldn't spend the money. It's cost millions of dollars. They didn't want to do it. I told them, you'll make your money back in a few years. So because they wouldn't do it, I decided I would just borrow money from the bank and I would do it myself. So I took out a lot of loans, around $8 million in loans, and built the facility and bought all the equipment. Put my own name behind it so that if the loans didn't get paid, I would lose my credit. I would be bankrupt. And honestly, it's just good results that keep us going. Good results. So yeah, let's go to 3-4. We're going to move up to number 3-4 next. She's squiggling a little bit. I'm going to need your help on this one because we're not all the way in yet. Okay. Let me know when you're ready. Shot. That looks good. So anyway, I took a lot of risk. My wife took a lot of risk. Our family took risk to make this place happen. And I'm glad I did. I have no regrets. I've lost a lot of money over the years, but I've fixed a lot of people and improved their life. And that's what really matters. That's why I went into medicine.
Keep your arms still, please.
Lay still. You're doing great.
You're doing great. I need your arms to loosen.
So anyway, that's a long-winded answer to your question, but I can't do anything. I'm down by the nerve root. I can't. I need you to help me. So we're going to wait a minute. You could see the dilator tip, show that, at L3-4 on the left side. We're literally at the back of the disc, And because I couldn't get the guide wire all the way into the disc because the needle wouldn't go in, it's so collapsed, we're sitting right in the back of the disc. And I'm just going to wait a minute till my anesthesiologist gets her a little more comfortable. And then I'm going to basically, we're underneath the exiting route, so I feel good about it. But we're going to have to enter the disc without the benefit of the guide wire. Ready? I need you to pull the guide wire. Go ahead. Oh, take that off and pull the guide wire. Hold on, hold on. Go ahead. I'll try to let up a little. There we go. Good? Go. Go. Perfect. Perfect. Shot? Yeah. Perfect. Nice. Hold on, a little more. So I've basically introduced the dilator into the disc space, and look in front of the dilator. Show them the white thing. That white in front of the dilator is the disc space opening up, and that's kind of like air. They call it a vacuum space phenomenon. It's pretty cool. We happen to catch it with the x-ray just perfectly. Luis is a little nervous because I'm hammering over his fingers, and I've missed sometimes, but only when he's not doing a good job. Just kidding. Go ahead. We surgeons make jokes once in a while. You guys are supposed to laugh, okay? All right. Any other questions?
Yes, we have 2 questions coming from Nick Hollywood on Facebook.
Hi, Nick.
The first one, this is when we were going through the incisions. He asked, can you please name the muscles you get through in the incisions? And the second question, does the body recreate the nucleus pulposus after you remove the herniated part?
Hey, Nick. Let me try first. Yeah. So to answer your questions, there's no recreating the nucleus pulposus. That's something that's made in the uterus when you're a baby, like in utero, literally developing as a fetus. There's no recreating the nucleus pulposus ever. And there are lots of companies trying to make new nucleus. But the problem has always been, because there's so much force on the lower back, pressure, that it always, whatever they put in there pops out. And then it causes nerve damage. So nobody's ever been able to create a new nucleus. And the companies that are, it's a scam. I would never put it in. It doesn't benefit the patient in any way. And it just makes money for those companies. Are we doing all right? Yeah, she's fine for me. She's just a little reflex movements. As far as the muscle layers, what we're going through is we made a cut in the skin, and then we're going below the skin is the fat, and then there's the fascia of the paraspinous muscles. And your longissimus muscle, look at that. That's where her back pain comes from. Right there. And once we get into the muscles, the paraspinal muscles, then we end up popping through the front of the muscles into the foramen. How are we doing on irrigation? That was a piece of herniation there. You guys see that? Blue thing? Just came out. My visibility is not great. I don't know why. Any ideas? I don't know if it's dye. Everything okay, doctor? Yep. All right, I'm fine. I'm okay. I can work with this.
This good?
Huh? I would check the dilator, Luis. Yeah. I think you're going to have some disc material in it.
Yes.
Look at that herniation there. Here. So I don't know. Hopefully I answered your question satisfactorily. But you're never going to make more nucleus pulposus. Now, the disc will heal. Still wiggling a little bit, doctor. I don't know if you're... I'm okay with a little bit. It's fine with me. I just... All right, fine. I'm fine. But the annulus will heal. And the annulus is where all the problem is. It's not the nucleus. Everyone's looking at the wrong thing. Okay? The problem is not the nucleus, it's the annulus. There are lots of companies that will take your money and do things on your spine that don't benefit you, the patient, just to make money off of you. Okay? And someday, it's going to become evident to everyone what I've been telling you is the truth, and that is that the problem is the annular tear. That's the source of pain. Yes, there's no disc left. Yes, it's bone on bone. Who cares? Lots of patients have bone on bone. They don't have any pain at all. They have a normal life. They move normally. They have normal activities. They play racquetball. They windsurf. They golf. They ski. You don't need a nucleus pulposus, period. Okay, that's a lie that you need it. If you believe that, then you've been told something that isn't true. You believe something that isn't true. The nucleus pulposus is truly, most people don't know this, and nobody really knows it. It's an embryological remnant of the notochord. The notochord being an embryological structure that basically his job is to cause the differentiation into the three primary germ layers from stem cells into the three primary germ layers. Ectoderm, mesoderm, endoderm, okay? And those ectoderm, mesoderm, endoderm go on to form all the tissues of your body. Everything, muscles, bones, joints, skin, intestine. All of those organs come from your notochord inducing germ cells to form those primary layers. Okay, once the notochord is done with its job, this is a giant bone spur, by the way. It's a, calcified herniation right here. Yeah. Once the notochord does its job of causing differentiation into those layers, then the notochord basically buries itself in the middle of your disc as a nucleus pulposus. Okay? And by the way, when the nucleus comes out of the disc, it causes a lot of inflammation and pain and suffering. Okay? So that's why herniations hurt so bad. Come on. Damn thing won't float out. Great question so far. Any other questions?
Yes, we have a question from Teak on YouTube,
Oh, hi, Teak.
and they ask, will we be seeing Dr. Louise performing this procedure soon?
What are you talking about? Luis is helping me all the time. This is a two-person show. Well, Luis is the best assistant I could ask for. Great question, Teak. All right. We're just at the back of this L4 disc. There's really, this is all herniation, by the way, that is getting calcified. Calcified means hard. It's getting hard, turning into bone. We've talked about this before, dystrophic calcification, where damaged tissues in your body become calcified by your body over time. It's nobody knows why. I suspect it has to do with proteins that are binding to ions like calcium ion. and becoming basically calcified. You know what? Interesting. Okay. There is something that happens like that in nature, right? What is it? Fossilization, right? Have you ever seen a fossil? A fossil is when organic material, like a tree or an animal, becomes fossilized. Its tissues are replaced by sediments that are ions. They become hard, okay? And that's exactly what's happening. I guess for the first time I've ever said this, but the calcification of this tissue is fossilization of the tissue. It's quite interesting. Nobody's ever said that. But it's true. That's what's happening. Interesting.
We have another question.
Sure.
This comes from Canes25 on YouTube.
Uh-huh.
And they ask, can an EMG pinpoint precisely what may be causing nerve impingement or which nerve causing numbness?
Yes. Yes, an EMG nerve conduction study is used to pinpoint which nerve, or nerves plural, are being pinched and damaged and can cause numbness and tingling or weakness. Yes, that is the test we use all the time here at Duke Spine. Very important test. Actually, Luis is the EMG master. That's what he does. He does a lot of EMGs with Dr. Damola, who does most of our EMG nerve conduction studies. And yes, it can be used to pinpoint exactly where the nerve damage is happening. Is it happening in the neck, the back? Is it happening where the nerves roots come out of the spine? Is it happening further downstream in the extremities? So it's a very useful test. We love it. We use it all the time at Duke Spine. Just about done here with this one. I'm gonna try to reposition just a little bit more. That's the epidural space at 12 o'clock. It's very hard to see. There's a little bit of bleeding. That's why you guys are having a hard time seeing it. I'm having a hard time as well. I apologize. That it's microscopic bleeding. It's almost nothing. It's literally probably 10,000 red blood cells in the water at any one time. And that's really not a lot. Just about done here. A lot of this is bone spur, by the way. You guys see that? A lot of it's bone spurs. And I just want to make sure we get it all. Grabber. Other questions?
No current questions.
By the way, this grabber here is a wonderful grabber. And this is called a pituitary. It's an endoscopic pituitary rongeur. It's used by virtually every endoscopic spine surgeon. And you can see it's very limited in what it can actually do. It can't remove bone spurs. All it can remove is pieces that are already loose. And the laser is really needed to do most of the work. Everything okay? How's our fusion? She about ready to go home? Our fusion lady from earlier today, the first surgery, she was an L4-5, L5-S1 fusion. She's about ready to go home. I checked on her earlier, and I don't know if I told you about her.
Okay, don't lose.
She had some weakness with her foot, and after the surgery, the weakness was not 100% gone, but about 90% gone. So I think she's going to be really happy about that. I suspect her back pain is gone. All right, I don't know why my irrigation doesn't look good. Is there a reason? No, it's not that. It's too slow. I feel like we're at the end of the bag. Look at the horrible pressure right here. This is nothing. Increase the pressure, please. That's better. Nope. I don't want to break the machine or pop the bag, but that is better. All right. I don't see anything pinching the nerve. It looks good. I think we're done. Lay still. Any other questions? Why don't we run our video? Lay still. On how does the Duke laser disc repair actually work, Henry?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. We are getting ready to do our last disc on the left, and then we'll move to the right. This last disc is going to be the L4-S1. And nice job there, Jordan. Let's go ahead and place the guide wire. We do go through guide wires. Okay, nice. So the problem is if I put numbing medicine down by the actual disc, it's going to affect her nerve roots and make her weak and numb after surgery from the medicine. So it's like having a epidural or caudal block. Show me. Uh-huh. All right. Excellent. So let's put some more numbing medicine in the skin. Yep, and I'll put some down the tube. Yeah. That's fine. You can have whatever opinion you want. Or you can trust me. But I will do as you ask. All right. So we've shown the video on how does a herniated disc cause back pain. Shot? Correct? Shot? Henry? Henry?
Yes. Yes.
I
Apologies.
need to hear answers, otherwise I'm just going to...
Apologies.
Well, let's get it together. Yeah, there's bone in there. I cannot inject. Told you to clean out the tubes. Shot? 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 You just need another guide wire. I mean, you need to use this guide wire. Shot. AP. Lay still. Coker. Nah, forget about it. Shot. That's good. All right, lateral. So you can see on the left side of your screen there, if you went to the x-ray, that's the dilator tip plus the guide wire in front of it. We're about to take the guide wire out in just a moment. I need to see though, yep, looks good. Go ahead and take the guide wire out. Yeah, so we're literally at the back of the L5-S1 disc. Shot. Very collapsed. You can start to see it open. Shot. Yep, we're in. So I'm going to give it a minute. She okay? All right, let's go. Oh yeah, I want to put the other needle in. You mean this one? Oh yeah, it should be big enough to put it. There it is. It just went in. Look at that. It went in. So very nice, very nice, very nice. So Luis was smart, smarter than me, and he said, hey, while you got that disc space jacked open on the left, put the needle in on the right, because I was bumping up against the back of the disc. He was right. Shot. Okay. Shot. So I'm advancing this tube over the dilator. That's probably as good as we're going to get it. Very tough to do because these discs are so collapsed. Shot. She hot?
Yeah.
So you can see the tube is still there. We got the dilator out. Clean the dilator, please. Yep. Beautiful. Questions from our audience? Not an easy case for us by any means. Very, very challenging to do, but we're getting it done.
No current questions.
So after this, I'm going to go to the other side and do the same 3 discs on the other side. All right. Remember, we did not do the discogram on this side. We can actually do it through the other one. Let's do that. Let's show them. It's going to be kind of cool if we do this. Hook it up to the L5-S1 needle on the other side. You understand what I'm asking you to do?
Yes. You want me to flush it too?
You don't need to flush it.
No, flush it, but you want to push it or no?
Oh, hold on. I do, but give me a second because there's still some blood. And now we're inside the L5-S1 disc. Hold on. Get it on there. You're just going to do a small amount. Okay? You guys see the L5-S1 disc, right? You guys see it there, the crack? Now Luis is going to give you a little bit of discogram dye from the other side. Watch. It's going to turn blue. Yeah, it went black. There it is, blue. See that? So we did a discogram from the opposite side. How cool, huh? And we were able to do that because we jacked the space open and we put the needle in. The needle's going to be right down there, somewhere in there, right below that little piece of blood clot. All right, take this. Let's back out a little. Again, these discs, we're not taking their disc out. They're already gone. We're fixing the tear in the back of the disc. This tear is where the back pain comes from. She's under so much compression force, it's literally bending our tube. You guys see the tube?
Yes, we do.
The tube is not oval anymore. It's become, I don't know what you call it, geometrically the right term. Maybe Arias knows. The tube is squeezed. It's like a squeezed oval. It's compressed. I was never great in geometry. All right, that's kind of a lie. I was pretty good. I did get the state math award in high school. But math was not like what I wanted to do the rest of my life. My son, on the other hand, is a math whiz. And actually he's a whiz at pretty much everything. But math he's particularly good at. When he's not playing Clash of Clans, right? There's your herniation right there. Now these patients that have not so much disc left, They don't get big herniations. They get small herniations, okay? And those small herniations are in just the right spot, and the disc is already degenerated enough that small herniation causes a lot of problems for them in terms of pinched nerves and back pain. You don't need a giant herniation to cause symptoms. That's one of the things most people don't understand. I have a feeling I'm grabbing the needle. Somehow it feels like I'm grabbing the needle down there, trying to pull the needle out from the other side. I don't see it. Any questions?
No current questions.
Great. All right. Just got this last bit here to do and on this side, and then we'll be moving on. Look at how inflamed everything is, all the red stuff. It's all due to this little wad of tissue that we've been dealing with. Again, right where the nerve root is. So you get the leg symptoms. All scar tissue here from chronic inflammation. So see how she's moving right now? This is not skin. This is the most painful part of her L4-S1 disc right here. This is what causes all of her back pain. And we're almost done with it. So that's a bone spur, folks, right there. See that? That golden white thing? I just blasted it away with a laser. So you get all these doctors that say, oh, lasers can't get rid of bone spur. Yeah, of course they can. Those are doctors who don't do laser surgery. You're doing great. Everything's okay. Lay still. Almost done here. It's the worst part. The worst part right here. I need 1 minute, maybe a minute and a half left here, and then I'm done with this disc. Well, folks, if you're watching this surgery today, you're watching the future of spine surgery. All the fusions are going to go away. All the artificial discs are going to go away. Everything's going to be replaced with this surgery. Everything. Degenerative. No, not tumors. We're not going to replace tumor surgery with this, but spine tumor surgery. But most spine surgery is done not for tumors or infections or fractures. It's done for degenerative conditions like this. And laminectomies are damaging. The only reason doctors do laminectomy these days is so they can do a fusion tomorrow. By doing a laminectomy, they're weakening the patient's spine. They're just prepping them for another surgery. With Duke laser disc repair, we're not taking anything out. We're not destabilizing the patient's spine. We're not removing the bones and ligaments. We're removing bone spurs. 30 seconds. And then let's go ahead and show a testimonial while we switch sides, because I'm just about done here.
And I'm Dr. R. Duke Majan here at the Duke Spine Institute. I'm smiling because I'm sitting with my first surgical patient of 2023. I don't know if you realize that, but you were the first one of this year, of the new year. Now, you had the Duke laser disc repair done on your lower back because you had 3 bad discs, and we did that yesterday.
Yesterday, yes.
And here you are, 1 day later. How do you feel?
And I feel good. I feel good, and the pain that I've been suffering for months is gone. I mean, I'm a little bit sore, but that's from the surgery itself.
Yeah.
But otherwise, I feel good. Feel good.
Now, you've had back pain too, on and off for 30 years. We were talking about that. Tell us about those episodes of back pain. What do they do to you?
The first one that I recall was pulling out a sofa bed thing. And I got so far with it, you know, we had company and I was opening up the bed, and all of a sudden I just could not move. I I couldn't move. My husband had to practically carry me. So I was out of work for a week or so, and then at the chiropractor, and then gradually it got better. And I thought, well, that's fine. And I moved on. And then, you know, had a couple other times like that. One time I was drying my hair, getting ready for work with the blow dryer, going like this with my hair. And all of a sudden, it's like I couldn't move. I couldn't move my arm down. I couldn't, I mean, it was that quick.
Yeah.
And just, I was out again for another week, laying in the bed and doing all that stuff. And then I thought I was fine, but I always, not always, but for many years now, probably at least those 30, I had lower back pain, where in the morning I couldn't bend over to brush my teeth. You know, that would really hurt.
Yes.
So I had that.
Do you have that pain now?
No, I don't think so.
It's gone.
The pain this morning, I was the first time in a long time I've gotten up first thing in the morning and was able to walk and not have that awful pain, because first thing in the mornings was the toughest.
I'm so happy for you. So how is this surgery going to
I'm
help you in your life?
Well, hopefully I can, once I can at least walk again. I was not able to barely walk with a walker. I was very active in my church and my
So you
community.
want to get active again?
And being in such pain now since July, and this is the new year, I'm anxious to get back to, you know, my life.
Yes, of course. Well, you had 3 herniated discs in your lower back, and you can see in the footage where we went into each of those 3 discs, and I used a laser to clean the tear, where you had a tear in the back of each of those discs called an annular tear, and the jelly from the center was stuck in the tear, holding it open, allowing more herniations to come out. So I got rid of the jelly that was in there using the laser, cleaned out the tear, and now your body will be able to heal that for the first time in 30 years. So I don't expect you to ever have that pain ever again.
Thank you.
You're welcome.
I am so thankful.
Well, you had faith,
I am.
and you found us.
Yes, I
and
did.
You did what's right for your body, and I'm excited for you. So
I believe I did. I just kind of was led to you, and it just all went bing, bang, boom, and I didn't ask a whole lot of other people what they thought. I just did what I thought was I needed to do
good.
for me.
Is there anything you want to say to your fans out there?
I would recommend that if you do something to your back, that you take care of it early on. You take care of it right away. The longer you wait, the harder it is and the longer it takes.
It takes a toll on your life.
Oh, definitely. It has taken a toll on mine since this summer, for sure, where I have not been able to sometimes not function at all, barely be able to sit in a chair and be comfortable without squirming because I couldn't find that exact place where I didn't have pain. You know?
I don't see you squirming anymore.
No, I'm not squirming. I know. That's great. Sit here without pain.
Congratulations.
Thanks to you.
All right, have a blessed day.
Thank you. You do as well.
Okay, welcome back. And hopefully you enjoyed that experience from one of our patients who had this surgery done in the past. All right. And we are now on the right side of this patient. We finished the 3 discs on the left where we've moved over to the right. And she doing all right, doctor? Yes? She's doing good. So, huh? She's fine. She is fine. So I apologize for the fact that his visibility is not great, but this is what happens when you fix discs that have been damaged, very badly damaged. They bleed a little bit, and I can't prevent that from happening, but you can.
You put the asteroid on this side.
Mm-hmm. Luis is right. Luis is on fire today. If there was some type of a family feud event, you would win for your family, right? Oh yeah, look at that. That is the herniation. How do you say herniation in Spanish? Herniado? It's not horchata? I'm joking with you. I'm joking with you. Horchata, for those of you who know, is a drink, right? You want the horchata or you want the herniation? That's what happens when you guys don't ask questions, by the way. I start to get goofy. It's the end of the day. It's been a long day. Dr. Duke gets tired. The frontal lobe stops working. And you get a Phineas Gage syndrome. Anybody know who Phineas Gage was?
He was a railroad worker.
He was a railroad worker, that's right. In the 1800s? No. In the early... Uh-huh. Yeah. Yeah, that's right. A railroad tie iron or stake went through his brain. And
Very nice, polite gentleman.
yeah.
He was not a polite.
We all hear about this story in medical school, by the way. How before the injury, he was a church-going, God-fearing, tithing member of the choir, an upstanding citizen. Then the railroad spike went through his brain, didn't kill him, he stayed alive, and destroyed his frontal lobe. And he became a swearing, cursing, gambling, just no self-control. Notice I said gambling because he was a gambler after that. Gambled all his money away. Anyway, they figured out that the frontal lobe, that part of the brain that was damaged by the railroad spike that went through his brain, that was responsible for people controlling behavior. Think about that. What does alcohol damage the most, by the way? Frontal lobe. Okay.
Affects dopamine receptors too.
Yeah. So when you get inebriated, your frontal lobe stops working.
Substantia nigra.
Dr. Berndes said he's happy for anyone who wants to see it. He's going to show them his substantia nigra. Right? You're going to volunteer to show us your substantia nigra? Are you?
Too much substantia, not enough nigra.
Substantia nigra means dark substance, dark matter. It's found in the midbrain. It's found in the midbrain of the brain stem. And when you lose your substantia nigra, dopamine neurons, what happens? What happens? Anybody?
Develop a Parkinsonian.
You develop Parkinson's disease. That's right. Loss of dopaminergic neurons in the brainstem and the substantia nigra. Okay? Just about done with this disc. I need 10 seconds, maybe 15. This is the end of it. Let me just look south. Looks like there's a little bit still there of the herniation. Questions?
No current questions.
All right. Maybe right there a little bit. Pretty much.
I believe the other side. Mechanics,
30 seconds. A lot of bone spurs. I've gotten rid of the ones that need to be gotten rid of, left the rest. I can't get them all. Sometimes people don't understand. We cannot take the whole herniation out. It's not humanly possible. No surgeon will ever get 100% of your herniation. I like to say 50% is what's needed to get rid of symptoms. 50%. And I shoot for 80, 90. I know I'm not going to get 100. I try, of course. I'd love to get 100, but by trying to get 100, you can actually do more harm than good. That's it. There's the nerve root to the right. All done. Let me see, Luis. One more zap, actually, right here. Sorry. Thought I was done. Then my wife called me back. You're not done. You're not done. So I've been watching The Walking Dead again. I'm re-watching the series. I remember when that series came out originally.
Lights on, please.
Dr. Patel was crazy about it, huh? Actually, we all were. Great series.
Scope off, please.
Oh,
Yeah.
let's
No?
do, yeah. Just the one I didn't want to do it, but just a little bit. We're going to put some antiseptic. Agua. Any questions?
No current questions.
All right. Thanks. All right, done with 4-5. Next is going to be Luis, 3-4 or 5-1? 3-4?
Yeah.
Number 3-4. We're going to say 5-1 on the right for last. Best for last. Right? This patient, once again, has been suffering with back and bilateral lower extremity pain, weakness, numbness, as a result of a work-related injury. Now, she had prior problems in her back years ago, had to have a laminectomy done. She did great afterwards, but she is not wanting fusion, and I don't blame her. Most any other surgeon would have offered a fusion at this point, 3 levels, 3 discs, and she didn't want a fusion. I wouldn't want a fusion either. If I had the Duke Laser Disc Repair available, would you want a fusion, Berndes? No. Oh, Luis, you welded it? Take this. Oh no. What is that, 3-4? I'll be damned. What's it? Hold on, shot. Well, that's just gonna clamp down. Try. You want to use this? Want to use this? Okay, hold on, don't get too crazy. I think twisting is a better option. So we welded stylet with the needle together. Shot. They don't come out any further. Yes, no, maybe so. Relax. Rela. Shot. Here we go. Here we go.
Got it?
Dr. Berndes, how could you allow that to happen?
Have you ever seen that happen before?
Welding?
Like that? On an eagle?
Yeah, we do it every once in a while.
I can see that throat cover.
Is it okay? Is it sliding? Sacar. Sácale. Pronto, sácale. Sácale pronto. You like that? You like my Spanglish? You gotta have some fun in the operating room. If you don't have fun in the operating room, my God. Miserable.
I need a little more spot. No.
I'm gonna stick the num num on your toes if you don't behave.
They're so cold, I wouldn't even feel it.
Oh my God. This guy. This guy. You want it under the skin, right?
Go a little deeper too, because an inch. That's when she's getting the sensation. Put that throat cover.
Alright.
I know, because I'm bolusing the medicine.
Huh?
I'm the one bolusing the medicine. I know where she's sensitive. She's at the disc itself and at the skin.
Okay. Okay. As I say, órale, vato. Come on. Shot. All right, very good. This is L3-4. This is a painful disc, I can tell. You know what we can do is once we get in, we can inject a little more as well. Shot. This is the one that was collapsed pretty bad. Shot. You're doing great. Luis, pull it. You're doing great. Let's get some num num. Some num num num. You're killing me. That's skin num num. Deep num num. Deep. We ran out. You guys, when we do 6 levels, you got to have more than usual. Okay?
Also, I'm going to be heckling you guys.
Don't heckle me. Heckle Luis. Okay?
You can't heckle the guy with the hammer.
That's right. The hammer may end up on your toe. Uh-huh. Yeah. It's coming. Almost there. Yep, that should be it. That's good. Much easier to get into on this side now that we did the laser on the other. So there's now movement where the disc was, where there was no movement before. You understand? We're able to get in much easier here than on the other side. Oh yeah. Conan. Show me your sword. Very good. All right. Yalla Habib. Where is Omar? Left. You got to put that guy to work.
Clean office, fixing the rooms, meeting with the patients.
Is he doing good?
Yeah,
Good? Well, let's show our audience one more time how the Duke laser disc repair works.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. We are on our fifth disc. Apologize. 5 out of 6. And so far, our patient is doing really well. No issues with her surgery. Her discs are very collapsed, but that doesn't matter. That's not the cause of her problems. We're going to fix her back pain. We're going to fix her leg pain without doing fusions, without putting metal. She doesn't want metal. She's a beautiful woman, very elegant, and she doesn't want a big scar on her back. She doesn't want metal in her body, stiffening her spine, limiting her activities. She wants to go back to work as soon as possible, and this surgery will allow her to go back to work within a week or two. Normally, that's what I expect for her. We talked about other options like fusion, and she didn't want to do it. I don't blame her. I wouldn't do it either, knowing everything I know. There's a bone spur. You see that white thing right there? We're going to get it. Henry, you see it?
Yes, we do.
Right there.
Yep.
Blast it away. You see that? Beautiful.
Yep. Yes. Perfect.
The laser just eats it alive. It's like a great white shark versus a mollusk scuba diver. Right? Luis? Did you hear about the guy in Mexico who got his head bitten off by a great white shark last week? No? Yeah, there was a guy diving for mollusks, you know, little mussels and clams and things. And he was in Mexico, and a great white shark thought he was a seal, came along and bit his head off. Literally clean off, decapitated. Go check it out, it's in the news. Bizarre story. Very bizarre, because I don't normally think of great whites in Mexico. Yes, they are there. We know that from the great white trackers. But I always think of great whites as being in colder water. I guess it was colder, maybe it was the winter time there. But it makes me worry to get in the water even in Mexico now. Huh? How about you? Right? But the good news is if you get decapitated, at least there's no suffering. You know? It's over quick. I feel bad for him and his family, but at least he didn't have to bleed to death and drown and be terrified, you know? All right, any questions from our audience?
No current questions.
So here's what we're going to do. We're almost done. I'm going to take all the questions now. If you don't have questions, that's fine. You're still allowed to watch. And we're going to wrap this broadcast up in the next 10 minutes, okay? We're going to do our last disc, and then we'll wrap it up. I do want to give you all an opportunity to ask questions. Everything is going well. This is all scar tissue right here from the herniation. So it's herniation and scar tissue together. It's the herniation that causes the scar tissue by creating inflammation. All right, looking good. Is Carl still there?
Yes, they are.
So Carl, you see what I'm doing with the laser here? This is the annular tear. Literally, I just cleaned it out completely with the laser. I got all the tear cleaned. It's like cleaned out, gone. And got rid of the inflammation tissue on around the side. The herniated disc is gone. There's really not much left, just a little bit of this right here, which I'll have out of here in about, I don't know, 30 seconds. It's quick. And then we'll move on to our last disc. But this is the annular debridement, folks. This is what gets rid of the back and neck pain. Everything okay, Dr. Burndes? You're like looking around like you're looking for local anesthetic or something. On our field, right? Right on our field. You want us to put it in the patient. I found some too in the patient. Just about done. By the way, that is all the way through right there. This is a little vein right here. But what I want to show you is that's the epidural vein, and then there's the back of the disc. That's the posterior longitudinal ligament. It's a ligament that runs behind the disc. So I've cleaned all the annular tear out completely. Very happy. Done. And things are going really well for this young lady. Just about done. One more to go. It's a little antiseptic. We put some antiseptic in each disc as we're finished. This is standard operating procedure. I like being able to say that because it is an operation. So standard operating procedure is to irrigate your surgical incision with an antiseptic. Every surgeon that I know does it. It gets a little bit of the blood and debris out, but it also allows some antibiotics to get down there, and if there is any bacteria in the wound somehow, it kills them. Okay, done with that one. Notice the whole surgery has been done through two tiny little cuts. That's the beauty of arthroscopic surgery. There's no need for a big incision. Remember the earlier surgery today with the fusion? That was a big incision. Last one. Then I'm going to go check on the fusion patient. She should be able to go home soon. Is she almost ready? She should be dressed and ready to go. Any questions from the audience?
No current questions.
Are there people actually watching?
Yes, we have a good amount, actually.
All right. Well, folks, type up your questions because we're going to end this broadcast in about 10 minutes. We're not going to do post-op question and answer. I got to go say goodbye to my fusion. And, yeah, perfect. Good job, Luis. So go ahead and type your questions up. In the meantime, we're going to run one more educational video. No. What are you doing? Excuse me. What, Sean? It disconnected? I've never seen that happen. Have you? Sean, leave it alone. AP? I've never seen that happen. That's amazing. Let's just verify everything's still in good position. Oh, it's perfect. Lateral. So our needle, for the first time I've ever seen, the top has, wait. Let me do this. The top is literally disconnected. Shot. Good. Let me have it. I've never seen the top disconnect. Ever.
That was the one that was.
No, that's not. Shot. Uh-huh. All right, you got the guide wire? You hold the guide wire in, I'll try to take the needle out. So strange. So strange. It's very strange. I've never seen that ever happen. Oh, shot, don't move. Oh, good. So the guide wire stayed. Good job. That was very bizarre. Well, it worked out in the end. Just so you guys understand what we're talking about, literally this stem came off. Can you see that, Henry? There's no needle.
Yes, we do.
So we got lucky, we were able to get it out. Wasn't easy. All right, last disc shot. So let's run have we run the last video shot? Henry, have we shown that video on what causes back pain?
Yes, we have. We'll show it again.
Last video for you people watching, and we'll be done soon.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
More num-num. Welcome back. We're on our last disc. This is L4-S1. This is the worst one. It's totally collapsed and arthritic. And we're gonna put a little more numbing medicine in. It's offset. I understand we have a question.
Yes, we have a question from Best Sports Media TV
Let's
on
see.
YouTube.
Very good. We'll take it.
And they ask, how long does each disc take to repair roughly?
It's roughly 15 minutes per disc. Let me do it. But like this case, it's not 15 minutes because these discs are so collapsed. Yeah, we got to pull back the dilator. Broken? Wow. Yeah, this case is a really tough case for a lot of reasons. I would bring the, what's it called? The vice grip as well. I don't think we're going to get it without a vice grip. But on average, for a typical disc, 10 to 15 minutes. I'm just telling Henry the answer. I don't think you're going to get it with that. You need the vice grip. We're just going to have to pull the whole thing out. We're just, no. We're going to have to pull the whole thing out. Yep. Both tubes. So I need a towel or something around it. And I'm going to try to twist it out. She's just so compressed. Sean? Yeah, it's not moving. All right, you can try. Don't break it though. Is it moving at all?
Yeah, I mean, I can twist it.
See, shot, bring it back. Try to bring it back. So this disc is so collapsed that it's squeezing the tube and the dilator together. And we're having to pull both out. Damn. Just get it back further. Keep going. Get it halfway. That's good. Keep going.
More?
Yep. Nice job, Luis. Jeez. I don't know what I'd do without you, Luis.
We have
I would probably cry.
we have another section. I mean, like yeah, there you go.
Take that off. Don't take it out any further. Oh, all right, that's fine. That's good. Yep. I don't think we can do anything more on that one, honestly. That's it. We're done. Put pressure. So I think we're fine because we reduced the herniation. We already treated the discogenic pain on the other side. For those of you who weren't here for the whole surgery, in the very beginning, and I'll show you this while we're putting some pressure. And the reason we put pressure is, remember, we went through the muscle. We didn't damage the muscle, but we did go through it, so there could be some bleeding. We want to hold pressure in case there's vein bleeding. Can you take the scope? She had 10 out of 10 pain at L3-4 and 9 out of 10 pain at L4-5. We didn't get to test L5-S1 because we couldn't get in it at first. Our needle was at the back of the disc but not in the disc, so we couldn't do a discogram. That's why we didn't do the discogram at 5-1 until we were actually in it from the other side, and then we did the discogram. That's why we had the blue stuff come in at 5-1. But overall, I think she's going to be really happy with her results. I'm very happy with the surgery. It was hard, not because she's a big patient, but because basically her discs were so collapsed down. The bones were just squeezed together. All right, no hematomas. It feels supple. She feels great. Doctor, great job. Thank you. Good job, everyone. We have one more surgery to go. It's a single level. We're doing one disc. Anybody know what disc we're doing on the next one? L3-4. Right approach. Good. All right, so we're going to end the broadcast. I am going to go see my fusion and see them off. And we'll be back in 30 minutes or so for our last surgery.